Okay, welcome everybody to today's webinar on stance control braces from the FSH Society. I'm delighted to introduce to you Abbey Downing. Abbey is, I guess I should say, an orthotist. I'll let her introduce her credentials and where she is properly so that I don't screw it up. Without further ado, I also want to mention we have on the line Katy Eichinger from University of Rochester, who is one of the leading research physical therapists in FSHD. She wrote our FSHD physical therapy brochure, and she'll be contributing some comments and questions after Abby's presentation. And we also have Kathy Senecal, who first introduced stance control braces to me, and was really the inspiration behind the idea of having this webinar, because we realized a lot of folks don't know about this type of bracing. So with that, Abby, I'll turn over the mic to you.
Great, thank you so much, Joan. Again, my name is Abbey Downing, and I am a certified prosthetist orthotist. I work at Hanger Clinic in Wethersfield, Connecticut. A certified prosthetist orthotist is a clinician who specializes in prosthetic and orthotic fittings. Prosthetics being devices that replace missing body parts for individuals who have undergone amputations, and orthotics being the brace side of our field for individuals in need of braces for their body to supplement muscle loss or other deficits or alignment issues that they are combating. So thank you so much to June, Kathy, and Katy for being here today and for inviting me to speak to the FSH Society. I'm honored to be here, and I'm excited to tell you a little bit about orthotic management for the FSH population, with focus, of course, on stance control braces. All right, just briefly, I'm sure many people on this call are already aware of this information, but in regards to the muscular progression of the FSH condition, typically we see weakness in the hands, shoulders, and arms first, followed by weakness in the most distal aspect of our lower extremities. We're kind of down towards the ankles, and then later in the disease course, we can see loss of strength or deficits or deficiencies in strength in our quadriceps. Of course, quadriceps being the major muscle group on the front of our thighs. The quadriceps are particularly important for walking. They are the main muscle group that help control the knee. And the quadriceps will both flex and extend, or bend and straighten the knee throughout the walking process. And functioning and strong quadriceps are particularly important for normal ambulation. Let's just talk briefly about the gait cycle and what we call normal gait, or the normal ambulation. Let's see. Beautiful. All right, so during normal walking, the knee continuously moves into flexion and extension, from a bent position into a straight position, and is repeated throughout the entire gait cycle. So the ability to control the knee and to stabilize the knee through use of quadriceps certainly is a very important one for our mobility and our ability to walk. This diagram here is a quick picture of what we call the gait cycle. It's just the different stages of walking, and I just briefly want to point out the position of the knee. So here on the left, we have, this is the right leg we'll be focusing on. It's the dark blue leg in this slide. So here on the left-hand side is what we would consider the beginning of the gait cycle. This is just one single step. So all of these things happen to our body throughout one single step. So here at the beginning of the gait cycle, we see the heel hits down first, the knee is slightly bent. It continues to bend, and then it straightens as all of our weight is transitioned onto that leg. And then the bend process begins again, or the flexion process begins again, as we get ready for the toe to leave the ground. The knee bends and continues to bend throughout what we call the swing phase of gait. The swing phase of gait is the part where the foot is not in contact with the ground when we are actually progressing that leg through. And then, of course, it straightens again. So when our heel touches the ground, to signaling the end of that single gait cycle, we ensure that we have a foot that is stable. Let's see, a leg, excuse me, it's stable to accept our weight. So as you can see, it is very important for the quadriceps to be functioning during the gait cycle, and it's equally important for the knee to allow to be bent and straightened throughout walking in order to establish a normal or maintain a normal walking pattern. So what happens when we don't have functioning quadriceps? What is the issue here we're really trying to address? Later in the FSH condition or progression of the condition, when we can see loss of quadriceps strength, these are just some a few concepts or conditions or obstacles that we commonly can see. When we don't have strong quadriceps, we often will see an increase in falls. This is because as the body transitions their weight onto the leg, the knee can give out and buckle and cause one to fall. We also can see a decrease in mobility. And sometimes that is because of fear of falls or lack of confidence or stability, which relates to a decrease in independence, and also an increase in what we call overuse conditions. So overuse conditions are kind of exactly what it sounds like. It is when we are using other parts of our body to supplement lost strength. So for example, if we have decreased quadriceps strength, one may see an increase in reliance on the upper extremities, for example. If that knee's buckling and giving out on us and we're not feeling safe to put our weight on it, oftentimes you will see an individual transition to something with a little bit more stability, like a walker. Perhaps they go from a cane to a walker. Now, that's particularly problematic in the FSH population, given that the upper extremities typically are the first muscular groups to be involved. We also may see other overuse conditions like maybe some hip pain, like this picture is showing here. And we'll get into a little bit later as to why, but basically when the knee and the quadricep isn't as strong as we need it to be, we overly rely on other joints and other muscle groups to give us stability that can cause actual pain and problems in those joints as well. So where does orthotic management come in? So when we're dealing with quadricep muscle deficits or decrease in quadricep strength, we really are talking about the introduction of what is called a KAFO. A KAFO is a simple acronym for knee, ankle, foot orthosis. A knee, ankle, foot orthosis is a custom-made brace. Orthosis is just the medical term for brace, so you'll hear me use that term quite a bit throughout the presentation. It's just simply a brace. Oops, excuse me. So a KAFO is a custom-made brace used to support muscles, immobilize joints, and or correct the position of a knee, ankle, and a foot, hence the name knee, ankle, foot orthosis. It commonly can be made of metal, plastic, or a combination of materials. And more recent in our field, we've seen the introduction of carbon fibers. So I think when people first think of KAFOs, more often than not, their brain goes to the movie Forrest Gump. And while I love that movie, it is not an accurate representation of what KAFOs look like or function like in today's world. We've made significant advances since the introduction of the KAFO you see in Forrest Gump, and we're going to talk a lot about those today. So there are a few different orthotic options or knee joint options that can be incorporated into a KAFO to give us the knee stability lost when our quadriceps aren't functioning. There are methods that date back hundreds of years, and those include locked knee braces, locked KAFOs, unlocked knee orthoses that include offset knee joints. We'll talk a little bit about. Again, these are the types of technologies that have been around for hundreds of years, and they've been incorporated into KAFOs to give us the stability needed or the stability we're looking for when, in fact, muscle strength has been decreased. More recently, we have the introduction of two different technologies, one of which is the stance control brace. The stance control brace is what I'm really here to educate you the most on today. This is a KAFO, so it is a long leg brace that automatically locks and unlocks throughout the gait process. Before we were talking about the gait process, the gait cycle, and when the knee bends and straightens. And basically when the knee is in a straight position and the foot is in contact with the ground, a stance control KAFO will lock and the knee will be provided with additional stability through the device. And then when our weight's transferred to the toe and we're getting ready to lift the leg off the ground and swing it forward, the device is able to sense that or to tell that it's time to release. The knee joint will unlock, allowing the knee to bend and for a natural progression and swinging of that leg in what we call the swing phase. I think worth noting is there is also a more recent advancement in our field called the SSCO. The SSCO we won't talk much about today, but I do want you to know it is in existence. It is a computer-regulated stance and swing controlled orthosis. I know that is a mouthful, but basically what it is it is a KAFO that has a special joint on it that consists of a computer chip, a little microprocessor, and a hydraulic unit. And that technology controls every aspect of the gait cycle and gives it stability, different levels of stability depending on what's needed from the user. All right, so briefly, why do we have stance control orthoses, or what are the issues that stance control orthoses can resolve for us in relation to other orthotic options? You know, lock knee orthoses, or the type that Forrest is running in Forrest Gump, offer some advantages, undoubtedly. They are extremely stable braces, meaning that knee joint is not going to bend as long as it's functioning properly. And they do allow us to get up and move around in the absence of muscular strength. However, they use a lot of energy for individuals to walk with. And they change the way we walk, and they introduce what we call deviations in the normal gait cycle. We'll talk a little bit about that in the next slide. But basically, in order to move a leg forward or take a step with a knee that won't bend, the body has to adapt in certain ways, kind of deviate from norms in order to swing that leg forward. Also with locked knee orthoses or locked knee joints, we end up having one limb longer than the other. And the reason for that is when our knee bends, it actually shortens. And that's what allows us, that's one of the things that allows us to clear the floor well, so we don't stub our toes or drag our leg when we're taking the step. And when we take away that ability, while we do gain mobility, or stability, excuse me, it's at the risk of losing the mobility. Also, we see we can see secondary medical complications that arise due to that wear and tear and the excessive motion that we're relying on other joints for. These are just three quick common gait deviations that we often will see when people are wearing KAFOs that lock the knee out. The picture on the left is showing an individual with excessive lateral trunk lean. So if you look at the trunk here, up and down the body, this individual is leaning to the left in an effort to progress or swing that right leg through. This is an abnormal motion that is not necessarily efficient during our walking process. We want to spend most of our energy going forward and back and not side to side. And furthermore, this can cause, this excessive lateral trunk motion can cause pain and orthopedic syndromes for the spine itself, or the lower back. This middle picture here is just showing another common gait deviation we see in a locked knee gait, and that would be circumduction. As you can see from the picture, the leg is swinging around to the side because we're not allowing the bending, the natural bending of the knee that needs to occur. This puts a lot of wear and tear on the hip joint and can cause overuse conditions in the hip. The last condition, or the last deviation that this slide is illustrating, would be what we call hip hiking. And what's happening in that diagram is that individual has to elevate their pelvis or lift up their hip on that left-hand side in order to get that left leg to swing through. Again, this is an abnormal motion, and it can cause overuse and orthopedic conditions to develop in the spine and in the hip. The reality of locked knee orthoses is simply that individuals using them are not compliant, or they aren't being used. Out of all the users who are prescribed locked KAFOs, only 58 to 79% of them, depending on the research you read, simply are not using them. So while they do provide stability and help supplement quadricep strength that's been lost, because of the energy cost that's used to walk with them, they're simply not being used. I think also worth noting is there is a lot of research that indicates that it's unclear as to how much locked KAFOs even prevent falls. There is absolutely no guarantee that a locked KAFO is going to KAFO, is not going to prevent a fall. And part of that reason is that sometimes there's user error, the joints don't lock, or simply having to shift your body and move your body in those abnormal ways disturbs your balance so much that you can lose your balance and fall over. This is just a quick little graph that talks a little bit about the pulmonary and cardiac stress that's put on the body when we don't allow the knee to bend. And this is why it's so important that stance control orthoses are at least considered when we lose knee strength and we lose knee stability. When we don't allow that knee to bend, we can see from the top graphs here that the oxygen rate, or the amount of oxygen someone has to consume when walking, is significantly greater than when we allow the knee to bend. The red bar here indicates the users who are using a brace that locks the knee throughout the entire gait cycle. Those are the users who are walking with that stiff leg or peg leg position, versus the individuals who are wearing stance control braces. These are the ones that are automatically locking and unlocking. And we can see about 11 to 12% decrease in pulmonary stress, or we're not putting as much stress on our lungs and our ability to breathe. And the same goes in terms of cardiac stress. Our heart rate goes down when we are using a brace that provides greater efficiency. Another option that I think we should at least touch base on is this is an unlocked knee joint. Okay, so this joint itself offers stability when we lose quadricep strength, but it never locks. We get stability simply by the alignment. And what I mean by that is this is a picture of a KAFO, or at least part of one. This top section is where the thigh would go. This bottom section would be where the calf would go. This would be the knee, the front of the knee, and this would be the back of the leg. So here, this circle right here is where the joint of the knee KAFO is going to bend. Now, as you can see, it's kind of back further than where the bars are. So what that means is the brace itself is going to bend behind where the actual knee will bend. And through this, we gain some stability. Advantages are that it does not lock, meaning that you don't have to walk with a stiff knee or a peg leg, and therefore we will not develop any of those gait deviations and overuse syndromes we were just talking about. However, not locking is also a disadvantage. The knee can still buckle. It can be unpredictable, particularly when we're walking on uneven terrain, like down a hill or over our backyard to garden or mow or what have you. And because of that, it most likely will still require quite a bit of support from an assistive device of some sort, whether that be a cane or a crutch or a walker. So in-step stance control devices. So you can see from our previous conversation that in the absence of knee stability, our options that have existed for hundreds of years, locked knee braces and unlocked knee braces, really don't satisfy all of the goals we're looking to obtain. A stance control knee brace kind of will fill that void for us. This is the orthosis that will automatically lock and unlock. And what it does is it provides the knee free motion during that swing phase. So when our leg is in the ground and we're swinging it forward, it will allow the knee to bend. This will increase our ability, our efficiency in walking, meaning our endurance is greater and we don't get as tired as quickly, and it decreases the energy cost on the rest of your body. It also allows for a more normal walking pattern, and it does provide that positive lock when the foot is in contact with the ground. So unlike the unlocked joint we just talked about, there is a positive lock in this brace or in this category of braces that will lock when the foot is in contact with the ground to prevent the knee from buckling. This also decreases cardiac and pulmonary stress. Like everything in the world, though, there are some disadvantages to this technology that we're going to talk about today. One of them is that this is one of our more involved technologies. It's one of our more advanced technologies in the bracing world. And because of that, it's going to require practice in physical therapy. It's going to require an individual who is willing to go through a therapy program and who is willing to work diligently with their therapist in order to learn the technology and gain the greatest benefit. The other part is of course, there are more moving parts in this because it has a cyclic motion it goes through, and there's a locking mechanism that is cycling throughout our walking process. And as we all know, the more parts that move, the greater the chance of mechanical failure. So particularly some of our lighter weight devices like this picture shown here, this can be a more delicate stance control brace, mainly because it's meant to be extremely lightweight. This brace here is under 2 pounds or right around 2 pounds. In order to achieve that, we have very thin cables and small bars, and it can be a little bit more of a delicate brace. And with all that motion, unfortunately, there are occasions when the device is not functioning or it needs to go in for repair. Another disadvantage we're going to talk a little bit about today is most of the stance control technology is almost always incorporated in this long leg brace. So this is, while it's the knee that we're mainly looking to provide stability to, in order for this technology to work, for the most part, we are almost always talking about a long leg brace. So it will cover the entire leg, basically from the top of the thigh all the way down to the toes. All right. Here's a video of an individual walking with a locked knee, a locked KAFO and a stance control KAFO. The video on the left here, of course, is the locked version. As you notice, his knee is never bending. And the video on the right is the stance control KAFO. A few things I would like to point out here. On the video on the left, you will see, if you compare the two, this gentleman has a greater dependence on his crutches in comparison to the video on the right. He's almost pushing down through his hands on those lost strand crutches to lift his hip up and swing that leg forward. So this causes, pain and excessive stress and forces that are being transmitted up into his arms. This is particularly problematic, again, for the FSH population, given that more often than not, those muscles are already going to be compromised. You also will see that hip hiking motion kind of right there. If you notice, it's a quick little moment right there. He has to lift that hip up towards the ceiling in order to get that leg to swing through. And the last thing I'd like to point out in this video is the trunk motion. If you notice on the video on the left, this user is leaning forward more. He has less of an upright posture as compared to this video on the right, where he's wearing the stance control brace. Just briefly, if we focus on this video on the right, I'll just kind of point out when the brace is locked and when it's unlocked. So as I mentioned before, whenever the foot is touching the ground, it is locked. And whenever the foot is in the air, it is unlocked. So again, focusing on this video on the right, we'll wait for it the brace locks there, unlocks there, locks there, unlocks there, locks there, and then we'll unlock for the next step. So you can see that the cycling action of that knee joint goes through many cycles with, throughout one's walking, all one's walking throughout the day. All right, so all the literature and research that's been done on the benefits of stance control have really kind of concluded the same thing, that assuming that the patient has the ability to use a stance control brace, and we'll talk a little bit about who does and who doesn't in a moment, there's a significant advantage of using this technology over a more traditional locked KAFO. And those advantages include improved patient satisfaction, improved walking efficiency, more physiological muscle activity. So this is a really important one for individuals with muscular dystrophy. And a locked knee orthosis is going to give the knee quite a bit of stability, but it does that without allowing the leg to move, the knee to bend, or the quadriceps to fire and contract and make a muscle. And the more we can allow the quadriceps to fire and give us this stability, the longer we can prolong the atrophy or the loss of the muscle mass. So it is very important when we talk about bracing in general that we never over brace, because providing stability through braces means that we are relying less on the actual body and the muscles in the body to give us that stability. And it's extremely important that if we still have muscle strength left, that we're using it for as long as possible. And that's only possible through the use of a stance control brace when it's bending and straightening. Of course, we also see reduced compensatory motions and just more normal gait kinetics and kinematics. So that's just basically saying that we're walking in a more normal manner. Okay, so how does stance control braces work? How does it know when to lock and when to be unlocked? And how do we, and these three categories also go into my decision as a clinician as to which type of stance control brace is appropriate for each individual. So stance control orthoses are not appropriate for everybody. And certainly there is a great deal of thought and consideration that has to go into the selection criteria. It is extremely important, and it is very helpful for this to be a team activity where everyone is working together. All orthotic intervention in general really should be implemented in this way. It's important to have a physical therapist involved that is very knowledgeable about orthotic technology in general, as well as the individual's deficits and goals. It's important to have a physician involved because they're technically the ones that will be prescribing this device. It's important to have family involved to give outside support. And most importantly, the user is really the middle or the heart of this team. If stance control braces are one of our, like I said, one of our more advanced and can be one of our more difficult braces to learn to use. And if the user is not in it and isn't really the one driving the whole team and wanting this technology and wanting to be able to walk more, walk safer, and continue to walk, this whole process, this will not work. So within the, again, there are three different mechanisms, or we call them activation processes. And what that just means is there's three different categories in regards to how the brace or how the knee joint itself will lock and unlock. We'll start down towards the bottom. The first would be a weight activated device. What this is a stance control brace can have a sensor in the bottom of it or in the foot plate. And that sensor simply senses weight and it senses the unweighting. So when the foot comes down and it makes contact with the ground, the sensor in the heel can sense that the body has, that weight is being transferred into the brace, and that sends a signal to the knee joints to lock so the knee doesn't buckle. And then as the step progresses and we get ready to to roll off the toe and pick up our foot, the weight coming off of the heel will send a second signal to the knee joint and tell it to unlock so the knee can bend and we can continue to take a step. Unfortunately, there are no current options for this technology here in the United States. It is being worked on extensively in Europe, and there used to be 2 different stance control braces here in the United States that were weight activated. Unfortunately, they're just not available to our market right now. The second activation process that will control a stance control brace is ankle activated. So this picture of this golfer on the right, he is wearing an ankle activated stance control brace. And what that means is there is a little cable. Think of it like it's a very thin cable. It's metal, and it runs from the ankle joint down here by his shoe up inside of the bar to the knee joint here by the knee. So it's motion of the ankle that tells the knee joint whether it should be locked or unlocked. So when the foot is pointed down or into plantar flexion, that puts slack in the cable, and it allows a little pin there in the knee joint to engage and for the knee lock for the knee to lock. And then as the toes are lifted up or the ankle lifts up and that leg comes forward, that ankle motion puts tension on the cable, which will pull the pin out of the knee joint and allow the knee joint to bend. So these ankle activated stance control braces do offer some of our lightest weight options. And they can get down to right around 2 pounds, which is extremely lightweight for a long leg brace. I think worth noting here, though, as if I can just bring us back to one of those first slides we talked about, what's very common in the progression of muscle loss with the FSH condition is that we commonly see a decrease in ankle strength before we see a decrease in quadriceps strength. So some of these ankle activated systems may not be appropriate for the FSH community if we don't have the ability to lift that foot or we have that condition called drop foot. Now that doesn't mean that every one of the ankle activated systems are not an option. It just is something that has to be taken into consideration by the clinician who is making the selection. The last category of stance control devices we'll talk about is the gait activated stance control braces. The gait activated ones are go through the locking cycle through hip motion. So these are the only category of stance control braces that can be used without a lower leg section. So if you see this picture here, this picture in the middle does not have a bottom section that would go along the back of the leg and a foot section that goes into the shoe. So these gait activated stance control braces can be incorporated into a knee brace alone as opposed to a knee ankle foot brace. But again, often with FSH, we need that extra support and stability of the ankle. I'm going to ask Kathy to speak in a few moments here. And worth noting, Kathy has worn both of these orthoses. She has worn these 2 different lightweight ankle activated systems in the past. And she is currently in one of these gait activated systems that uses the hips to lock and unlock. However, hers does go all the way down to the foot and helps lift her toes up a little bit so she doesn't trip, as she does have a drop foot condition or weakness in that ankle. So some obstacles that need to be overcome when we're talking about stance control braces. One of the biggest one is the importance and the need for physical therapy and training. I think I've said this multiple times at this point, so you can imagine how important this is. This is not a magic wand. And, stance control technology will help an individual stay mobile, walk safer, and walk with greater ease, but not without this component. It's important that the user has the understanding of how the brace is working, how it locks and how it unlocks. And it's important that they work in tandem with the physical therapist so that they can operate it safely and consistently. There are also some social implications that some users take issue with. Excuse me, this just goes into, it speaks to the presence of a brace. It is a longer leg brace, and certainly one's peers will see it. And sometimes from a social and an emotional, mental standpoint, this is an obstacle we have to overcome. I think it is worth noting, though, is our peers are much more in tune than we think they are. And if you are falling constantly, or they're not seeing you as often, or you're not getting out and interacting as you used to socially, they're probably more aware of those things than the fact that you're wearing a long leg brace. Now, as a clinician, it's easier for me to speak about these, but of course, I am not a user of this technology. And I think that at this point, I would just ask Kathy, if you don't mind, Kathy, if you could take a few moments at this point to tell us a little bit about your story and about your use of a stance control brace. I would greatly appreciate that.
Yes, and Abby, I'm really glad, and thank you very much for inviting me, June, and the FSH Society. I've been wearing these braces, I think, for maybe even 5 years, and I've actually worn all three manufacturers over time. And the social implication that you're talking about, you are going to get questions, and that's okay. You can either use it as an opportunity to educate, or you can just simply come up with some kind of response that you'd like to get. But the fact that it's a real game changer for me, and I would love to see this opportunity offered to other individuals with this disease, because it really does make a difference. It keeps you out and about in the world in a safe way. So if the one thing too that has been talked about, it really takes a team to work with you, and it takes dedication on your part, because this brace does not walk for you. And I go to physical therapy now once a month, and we work on walking, because as the disease progresses, your body changes, and your orthotist will make adaptations, as Abby has done, as my disease has progressed. So working together as a team can keep you walking longer and better, and really make a big change in your world.
Great, thank you so much for that, Kathy. All right, so I'm just going to wrap up the presentation part by summarizing a little bit of the things we talked about. Stance control brace certainly can increase one's safety and their mobility. I don't know, I think everyone's goal on this call or on this webinar certainly are to stay out of wheelchairs. We all, to the best of our ability, we all want to keep moving and keep grooving. It does require successful usage of stance control technology, does require a willingness of the user to participate, and a knowledgeable clinician. So we're all on this webinar today to learn about stance control technology, because in all honesty, it is probably one of the most underutilized braces in the entire orthotic realm, not just with the FSH community. And because of that, they're not every clinician or every orthotist that you're going to come across may be experienced or comfortable in this technology. So in order to be successful, picking a clinician or working with a clinician that has experience and has the ability to differentiate between all these different options is important. And that whole team approach, that also means working with a therapist who is knowledgeable on this technology. And I can tell you in my area, even if a physical therapist themselves may not have seen the technology, I am always willing to go to as many therapy appointments as needed to educate that therapist. And these physical therapists are experts in the gait cycle. That is what they do. They gait train. They help people walk more efficiently, more safely, and keep them moving. And it just requires sometimes a little bit of input from the mechanics of the brace, and you'll be off and running in physical therapy. So again, my name is Abbey Downing. I work for Hanger Clinic. I personally work in Wethersfield, Connecticut. On this slide, you'll see both my phone number and my email address. If I can help in any way, facilitate any conversation, help link anybody up with a clinician that's local to them, that if you're interested in this technology, please don't hesitate to reach out and let me know. I think at this point, if we have any questions, I'd be happy to answer those. Please feel free to direct any towards Kathy as well. I know Kathy, again, she's been using this technology for quite some time, and I know she'd be more than happy to answer any questions that you may have as a user herself.
Well, thank you so much, Abby. That was, I learned so much. That was very, very informative. And thank you also, Kathy, for your comments there. I also wanted to know, we have Katy Eichinger on the line. She is a physical therapist, and she had, in a conversation with Kathy, had expressed interest in learning more about stance control braces. So, Katy, if I can bring you on if you have a question or comment that you'd like to make. Are you muted, Katy? Well, I'm not sure. We can't hear you. So let me take a question from the audience, and then we'll see if we can get Katy back in audio. So, so one immediate question I think people have is, this is from Mark. He says, cutting to the chase, how much do these stance control braces cost, and will insurance cover it?
Sure, okay. The cost thing, to be honest, is a difficult question for me to answer. And the reason for that is twofold. The cost of the orthosis really is driven by one's insurance contract. So the cost of all bracing, whether it's stance control or any other orthotic device, really is set by contracts between the orthotic company and the insurance company. That being said, well, furthermore, I am also a clinician. I am not a reimbursement specialist, so I need to make a disclaimer there. I specialize in fitting, fabricating, and educating and teaching people how to use this technology. I don't do any billing. I don't work with insurance company. I don't set contracts. So this is a little bit of a danger zone for me. But I've been a clinician for, I'm going on my 14th year here, so I fit a fair amount of these. And I will tell you in a complete estimate, nobody can hold me to this number whatsoever. We are working in the ballpark of probably about $2,000 for a stance control orthosis. So I would say somewhere between probably $1,300 and $3,500, depending on the technologies we're looking at and the the insurance contracts themselves. Again, also in terms of insurance coverage, the answer is yes. 99% of insurance carriers do cover these devices. In terms of Medicare, which a lot of us have, Medicare will cover 80% of orthotic management, whether it's a stance control brace or any other brace. So Medicare does cover the 80% cost, just like a lot of the healthcare that they do cover. They do cover one of these braces every 5 years. That is the normal stipulation for Medicare replacement bracing. And when we're talking about reimbursement, I can't stress enough the importance of that team, because as a clinician, unfortunately, my say, even though I may be the more knowledgeable one on these technologies, has the littlest impact when it comes to insurance coverage. So it's important that we have a doctor, a physical therapist, and a whole team involved, so that if the insurance company does question the necessity, we have the ability to combat those questions.
Thank you. Let's try Katy again. Katy, can you?
Do you hear me this time?
Yes, we do. Great.
Okay, great. Sorry about that. I'm not so technologically inclined. But first, I wanted to say thank you to Abby for sharing her information with us. And as a physical therapist that works with a lot of individuals with FSHD, I just really wanted the ability to allow the community to know about these options for bracing. And certainly you as a resource, I know one of my challenges is to work with orthotists that can kind of go down this road with patients and kind of trial different options to make the best brace work. And I think something that we struggle with is that with individuals with FSHD is the pattern of weakness and what muscles might be strong and what muscles might be weak sometimes make it challenging to brace. And so I definitely, appreciate you being a resource for us. And I think I just want to also echo what Kathy said, is that as a physical therapist, we also want to help patients to be able to continue to participate in activities that are meaningful to them and improve their quality of life, and not let mobility issues hamper that. And so, again, just knowing that these type of braces are an option for people who have leg weakness, I think is really important. And then I guess one question I did have for Abbey maybe is, are there any minimal strength requirements for someone to be able to use a stance control brace?
Just unmute myself there. Yes. The answer to that is yes, but it's not necessarily a standard across all stance control orthoses. So, we do need to have some hip strength. We have to have, I would say, probably at least a 3 out of 5 for hip flexion in order to initiate swing. Hip extension is another important one, because obviously in the loss of our quad strength, we're going to rely more on that hip extension. So there certainly are hip strength requirements. There are not knee strength requirements or ankle strength requirements in order to be successful with this technology. And exactly what those requirements are really depends on what type of stance control brace we're talking about. So if we have weakness, a more weak hip, then there are options, more lighter weight options, and maybe like an ankle activated option as opposed to a gait activated option that would be more successful with that specific individual.
Sure. No, that's makes a lot of sense, and that's good knowledge to have. And then the only other question that I was thinking is, so a lot of these individuals that may have weakness in the quad, how is the one that is just at the knee suspended? Like, do you have fit issues or challenges if somebody only has quad weakness and doesn't have ankle dorsiflexor weakness, and how do we best address those issues?
Sure. Yeah, that's a great question. Anytime that we're fitting a knee orthosis in general, suspension does typically tend to be an issue. Our legs are cylindrical, gravity pulls down. It is difficult to keep that brace where it needs to be in order for, particularly in this technology, because the joint of the orthosis needs to align with the anatomical joint in order for it to function properly. So really, it's anatomy of the leg that's going to suspend this, and it's important that the clinician doing the fitting understands that. So we're looking for things like gastroc development. So if we have good calf muscles and we have a nice sized calf muscle, we can utilize that to suspend the brace and prevent it from sliding down. We also can oftentimes gain purchase over the medial femoral condyle. So where we would kind of just give a little bit of a pressure in that area to kind of grab that condyle and stop the brace from sliding down. So there certainly are techniques, but undoubtedly when we are talking about the knee orthosis alone, suspension can be an issue. There are also very simple, and actually this is the brace that Kathy uses. It primarily is a knee orthosis. It just has a very simple lateral extension that comes down, and not only does that keep it in the right place, but hers has a dorsi assist, so it has a little spring on it. It's literally a spring. I mean, it's a cable a spring wrapped cable, and it just gives her that dorsi assist. But equally as important, it suspends it, and they come at 90 degrees as opposed to set in dorsiflexion for those who have suspension issues. Maybe they don't have gastroc development, or they don't have a medial femoral condyle we can gain purchase over, but they don't need the dorsi assist. So sometimes we have to put that feature on mainly for suspension alone.
Great, thank you. I have a lot of questions coming in from our audience. So here's one from someone who says he has trouble walking, but still does it using a cane. but sometimes the leg will, when he takes a stride, it bends too far. It goes past lock and hurts a great deal. Would this brace help to prevent this?
Absolutely, yes. So that is a very common thing. We're talking about hyperextension there, often called recurvatum as well, and that is often a direct result of loss of quadriceps strength or knee strength and hamstring strength. And certainly, absolutely. So the brace has the brace stays vertical. It will not go in that back position. Yes, so absolutely, there is potential for this device to stop that from going backwards. Also, when our knee goes backwards, we get additional stability. So some people with all different muscular dystrophies, not just FSHD, will almost rely on that knee going backwards to give us the stability. So it's important, if we take that away and we don't allow that knee to go backwards, we incorporate something else to stop that knee from buckling. And in this case, I certainly would say stance control would be an appropriate consideration.
Great, thank you. Another question is, this is someone who had used a locked knee brace, I guess, and noticed when he had that, he stopped using it because of it, didn't allow him to exercise. It seemed to exacerbate loss of muscle, but also he said he couldn't trust being in a crowd because it would if someone jostled him, it would throw him off balance and cause a fall. Is that less of an issue with a stance control orthotic? Does it help with balance?
Yes, I would say it's less of an issue, absolutely, because you allow the knee to bend more normally. But I think that's where therapy kind of comes in and is so important, because as a stance control user, you have to know how to lock and unlock that brace and what positions of your body will achieve that. And I think Kathy can certainly speak to that. I can't tell you how many times we walk down our hallway, she says, oh, but we missed a step there. So I may make a little adjustment, but not only am I making adjustments, she's making adjustments to her walking, and she's identifying, okay, what did I just do that allowed that facilitated the proper function of that brace? Because just like this individual who asked this question, it can be very unsettling and disturb your balance significantly when you are kind of disturbed from the outside and your knee doesn't bend. So the same would go with a stance control brace. If it misses a step or you don't activate the unlock in the right way, and all of a sudden you're expecting it to unlock and it doesn't, that too could cause a fall, just like being kind of jostled from someone in a crowd. So that's why it's therapy and understanding of the technology is so critical.
Okay, thank you. Another question here. This is from someone who says she uses an AFO for foot drop and a walker. She's wondering if the stance control brace would help her walk more freely so she wouldn't need the walker.
Mm-hmm. That's a difficult question to answer from being on a webinar without seeing the specific individual. But something to keep in mind is stance control braces really are, the intention is to give the knee stability. So if this person's knee is not buckling and we don't have weakness in the quadriceps and the knees, then the technology may not be appropriate. It really depends on what we're using the walker for, other weakness in other parts of the body, and what the muscle strength is.
Okay. Here's
maybe yes, maybe no.
Okay, yes, that can often be the case. Here's a question from an individual who is no longer walking independently and using a wheelchair full time, but she's wondering if a stance control orthotic could be used for helping with transfer or for allowing her to walk for exercise, obviously, I guess with supports. Can you see using it in that context to help an individual who's pretty much wheelchair dependent and otherwise?
It can be, yes. Again, this is a maybe yes, maybe no question. It really depends on the strength and the rest of the body and what are our limiting factors, what's preventing us from walking. But absolutely, there are individuals who do ambulate or walk for therapeutically or for exercise only to maintain our normal body systems, get our strength, our heart working, our lungs, keeping our GI system working. And perhaps they walk something like 5 minutes a day, twice a day around their home or something of that, to that extent. And certainly this technology has potential to help in that case. Yes, it's not necessarily limited to individuals who are walking throughout their entire day and in their community.
Okay, thank you. Here's a question from an individual wondering if a stance control bracing should be considered as soon as we notice that we're starting to have weakness in the legs.
Yes, I would say probably the sooner that we consider that, the better. A big part of that is the longer we go with walking when we have progressive weakness, and we do develop things like that recurvatum or that hyperextended knee, those lax ligaments. We also develop walking patterns to compensate for our weakness that become increasingly difficult to undo.
Okay. Here's a question of asking whether the stance control brace can be used while one is driving a car, or does it have to be removed before you get in the car?
Yeah, Kathy, shake her head over there. She is correct. Yes, it does not have to come off to drive a car. It doesn't have to come off for any of your activities of daily living except showering. So we do not shower with this brace on, but certainly you could bend your knee for that. And Kathy, do you drive with your stance control on?
I also shift, so you can shift with this brace. Yeah, it's like a leg. Yeah.
Okay. Can the braces help with someone with rising from a seated position?
That's a tough one. Unfortunately not. They're not only can stance control cannot do that. I'm going to go out on a limb here. Said there is not a single orthosis on the market that will power somebody up from a seated position. There are some that will help ease you down into a seated position, but unfortunately we don't have the technology yet to help one get up out of a chair.
Okay. Are there other devices that are not orthotics that can help with that regard? Different types of
yes, and maybe even Katie could speak to this better than I can, but I mean, when I think of things, there are certainly there are powered recliners that have the automatic kind of remote that will help lift up, so you're, instead of going from a 90-degree position, it raises you up. But Katie, please feel free to jump in if you can figure out how to unmute you. Any suggestions on that?
Yes, there is a device called like the uplift seat, I think, or lift assist seat. That is something that can, again, just be portable and be taken to different areas where you may be facing the issue that you're having difficulty going from sitting to standing. And I do know that there's a lot of research going on in this area and a lot of companies working towards trying to develop more exoskeleton-like assistive technology that can help substitute for some of those motions that we don't currently have solutions for.
Thank you. I have a question from someone who's wondering if one can use the stance control orthotic on both legs. So if you have knee weakness on both sides.
Yes, you can.
Great. And then another from someone wondering if there are, I guess this touches on what Katy Eichinger was just alluding to. Are there any sort of motorized options, I suppose exoskeleton type options? You mentioned something called Kigo. I'm not familiar with that, but so I guess it's sort of powered orthotic. Are you familiar with anything like that on the horizon?
Yes, as Katie mentioned before, there are actually several on the horizon. That is a very kind of hot area in mobility right now, or are those exoskeletal type systems. They are all powered, and they will help fill a lot of these gaps in that traditional orthotic management isn't able to do right now. So to the best of my knowledge, I don't believe there are any out in the market here in the United States. available to like the average consumer. I know they are being used and highly researched in facilities like Walter Reed within the VA and other like still in the research and development type tech realm. But certainly, yes, those things are being highly researched and there's a lot of interest in those right now.
Okay, thank you. So we're a couple minutes past our time. I have one last question. I think then we can wrap up. So from your description, these braces do need to be customized to the individual. So for listeners out there, can you tell them, how do they get started? How do they find somebody who can help determine, evaluate them to see if this is an option for them?
Sure, great question. So yes, 100% true. All of these are custom molded braces, meaning we take a cast of the body. It is fit very intimately. It's not something that can be purchased off of the shelf. So the best way to kind of get this process started is if you're thinking this may be something appropriate for you, would really be to start with your provider or your physician. Hopefully you're working with somebody. A physiatrist tends to be the best doctor to focus on here. Those are doctors specializing in rehab potential, and they are the most knowledgeable in this technology. So if you're already working with a physiatrist, that would be the best person for you to go to and voice your interest in. You really can't get direct access to a clinician or an orthotist like myself without first going to your doctor. You do have to have a prescription for this device. If you don't have a physiatrist you're working with, but you're working with a physical therapist, I would encourage you to start there and to speak to your physical therapist about it. Perhaps they can facilitate a connection with a physiatrist or another doctor that may be able to prescribe the device for you and allow you to get into an orthotic office and meet with an orthotist or someone like me.
Okay, well, thank you so much for taking the time this Saturday afternoon. Thank you to our audience. We'll be posting this webinar on our YouTube channel. So again, thank you so much, Abby, Katie, and Kathy.